Well, good afternoon, everybody, and welcome to this EPR Network webinar. For those of you that don't know, I'm Hadley Stoller. I'm Chief Exec of Healthcare Innovation Consortium. I'm thrilled to be joined today by one of our EPR Network members, Orion Health, and particularly joined by Ian Binks, who's the Business Development Director at Orion. And we're here today to talk about the principles around making the single patient record, which is a key initiative within the NHS 10-year plan, a reality. So it's great to see you. It's great that you joined us. So thank you very much. And we look forward to hopefully some good conversation. So just some housekeeping. There's audio and video for participants has been disabled, but there are opportunities to comment and question and add feedback in the chat. So please do use that as a place to ask questions and engage with us, and we will check that as we're going through, and we will try and include people and people's views as we go along. The session is being recorded, and you will receive a copy of that recording within the next day or so, and also the slides that were shared today will also be with you post-webinar. So that's just some housekeeping out of the way. Thank you. So just a little bit about HIC, Healthcare Innovation Consortium. We're an independent consultancy. We specialise in digital health transformation. We partner with organisations both across the NHS and industry to deliver evidence-based, strategic and sustainable digital solutions and support really to improve patient care and drive workforce efficiency. We conduct readiness and maturity assessments. We help with procurement, options appraisals, business cases, implementation and utilisation, and benefit realisation. They're some of the organisations we've supported over the last 5 years. Of course, Orion being one of those. So that's just a little bit about us and who we are. So go to the next slide, please. Thank you. But we also do a lot more than that in terms of bringing communities together. So in this instance, the EPR community is a key foundation to NHS digital transformation. We have a growing EPR network. It's the UK's first and only, and we're thrilled to be the curators and delivery partners of the EPR network. We now have 19 members and growing, and it's a place for vendors, leaders, NHS organisations to come together and start to shape policy and the narrative around EPR success across the country. Alongside that, with our Partners Convensors Group, we host a number of regional and national events and summits. We go to all corners of the UK from next year, starting in Wales, which is happening next week on the 18th. Of November, and then back for the main England summit in March, and Scotland, Northern Ireland and Wales will also follow next year. So if you're interested in coming to EPR, EHR Wales, we'd love to see you there. I know Ian and the Orion team will also be there. So it'd be really great to see you there. There's a QR code. It's free to register for NHS colleagues, so it'd be great to see you there. If you're interested in coming, please do so. And obviously, I mentioned the EPR summit in England, and there'll be a link for that later on too. So, without further ado, I'm going to hand over to Ian, who's going to tell us a little bit about who Orion Health are and some of the successes they've seen before we then get into our discussion. So, over to you, Ian.
Cheers, Hadley. Thanks for joining us, everybody. So, I'll go fast on an intro to Orion. So we can spend the majority of the time on the meat of the discussion. But who are we? So we've got more than 30 years experience in healthcare. So we built from our foundation of really strong expertise in integration and interoperability into what we have now, which is a sort of world-leading platform in HIE and shared care records. So we now have more than 65 sites across the world. More than 150 million patients are covered by our platforms. And that platform is powering the shared care record for currently 9 ICSs across England as they stand today, pre-clustering, and about 10 million people of the population of England. So our 400 staff are spread around 12 countries in the world. So we do have a truly global presence. And we've recently become part of the Healwell AI family. That's a Canadian company specialising in clinically validated artificial intelligence tools, which we'll be bringing into our products currently. For those of you who are not sure what a shared care record is or what it does or the value of it, if you look at the bottom left, there's some stats from a case study in Mid and South Essex. It's one of our most recent deployments of a shared care record. So they've already got more than 8,000 users, which is over 82% adoption. They're projecting £3.8 million in annual savings on the shared care record. A 50% reduction in ED admissions from elderly fall-related and ambulance calls during some early pilots, and lots of great time-saving efficiencies. So really, a shared care record is a quite underrated platform, really, considering the size of the investment compared to something like an EPR. So what we're doing now, our main focus really is on supporting the national priorities. There are some really big key drivers for the centre at the moment, and we really want to be driving support for that. So we're focusing on helping the NHS deliver the 10-year plan by building on what works instead of throwing away digital assets that have already been invested in. We want to support the NHS's vision for a connected health and care system, and that's evidenced by where we've got to with some of our early adopters. So Devon and Cornwall, one of our customers in the Southwest, was the first shared care record to go live with integration to the version 3 of the National Record Locator Service. And also, the same customer, Devon and Cornwall, was the first shared care record to integrate directly to the NHS app. So we're really trying to bring together these sort of national systems and national programs with the regional blueprints that they have. And working directly with our customers and really heavily with Hadley and HIC, we're hoping to help drive that national blueprint for the single patient record and make sure that the centre is understanding the value of the assets that they have at a regional level with shared care records and how they can support what a single patient record is. And that's what we're going to talk about today. So hopefully it will be a lively discussion, but really it's about turning complex health and care data into a proactive personalised care, if you like. So the blueprint for the single patient record. There's a QR code in the bottom left where you can get a link to a landing page where we've got some really interesting information here, but it comes down to, I think, sort of 5 key points, really. Hadley and I can discuss this together with you, but point number 1, super important, a single source of truth. This is the whole point of a single patient record, right? Is that currently lots of different points of what could be considered a truth exist about specific pieces of information on a patient, whether they're in a hospital EPR, a GP system, something that was recorded in social care, something on a piece of paper that the patient has in their own home. The single patient record needs to create that single source of truth so that wherever you are looking at the information, you know that it is the most up-to-date, most correct version of what you need to look at so that the decisions you make are correct. For that, it needs to use a federated data structure. And by that, what we mean is we're not talking about physically moving data from one system to another and then storing it in 2 different places, because that becomes complex and really difficult to manage. When we talk about federated data, we're talking about being able to view from anywhere the up-to-date information, irrespective of where it's been recorded. So it's a window into other systems. And that's what we mean by a federated structure. It needs to ensure consistent semantics. When we talk about things in healthcare, language needs to be really specific. So when we're using different terminology to describe the same thing, it can cause inconsistency and it can cause bad decision making. So we need to ensure that when we're talking about this single patient record, those semantics, that terminology is consistent across the board. It should exceed existing integration standards. It needs to be wired directly into things like the FTP, things like the NHS app, things like the NRL, because it has to be consistent. We can't have different standards in different places. And the most important point to me, for me personally, because I'm very heavily invested in this, is it encourages citizen participation. I fundamentally believe that the more we participate in our own health information, the more agency we take over our health, and the more control we feel over it, and the more likely we are to remain healthy as opposed to getting sick. So I think we have to encourage citizens to participate in their health information, not just spectate over it. And that involves things like patient contributed data to about me forms or end of life type discussions and really getting people involved in the health information. Hadley, I don't know if you want to come in and add something to this.
Yeah, I was just going to come in there and just try and kind of wrap some of that up in terms of some principles here. But I think what we've kind of identified by working together on this blueprint and trying to translate the single patient record into something meaningful and understandable that we can kind of all relate to. There was also a white paper, I think, where that QR code will take you to, where we tried to put a bit more meat on the bones around these principles, but in essence, it's talking about I think not creating something new. I think we've all got the scars and the experience of when we've tried to roll out big national systems and programs previously. Wasn't all negative, but there was some good stuff too, and there's infrastructure that we're still benefiting from today from that previous those previous programs. But I think this is about using what's there now, building on it, and recognizing that ecosystem of technology that's already in place to try and create this kind of enhanced revised vision, really. So yeah, it's an exciting topic. It's very complex. There's lots to it, and hopefully we'll try and unpick some of that on the call today, really. So if I can, Ian, if I can kind of oh, actually, sorry, you want to just talk a little bit through about the nodes and what that national picture looks like, don't you? So yeah, go for it.
Yeah, sure. Just I guess to describe a little bit more about what we mean by the federated architecture, just to get everybody on the same page. You can see in this diagram, the bottom three grey boxes represent different shared care records. So the blueprint that we're proposing for the building of the single patient record is that the shared care records that already exist, that are already aggregating information from primary care, secondary care, tertiary care, mental health, social care, all sorts of different disparate areas of health and care that can be quite challenging to pull together. All of those different shared care records can fuel an aggregation layer in the middle. And then as well as that, all of those national services like the National Record Locator Service, the NHS app, GP Connect, Federated Data Platform can also fuel that aggregated layer. And that's where you access to view the information. So instead of trying to work out at the base layer where those three bottom grey boxes are, how we get all of that information that already exists in the shared care records and put those into a new single patient record, we think we should be building off those shared care records, finding out where the gaps are in those data, and then building that out at the local level and helping to fuel that national aggregation layer. We'll get into this, I think, in a little bit more detail in the discussion.
Awesome, great. Thanks, Ian. So there are three kind of core areas that I want to have a conversation and get your thoughts on if we can. So with the first one kind of focusing on kind of moving from EPRs to a single patient record. So from your experience, Ian, where do kind of current EPRs maybe fall short when patients move across care settings? And what's the real impact on clinicians and patients when that happens?
So I think where they fall short is exactly that point that you mentioned, moving across care settings. It's that transition between different areas of care that is always a fragile point in the process. And it can be really simple if you've got a very simple pathway and a relatively simple patient who's otherwise fit. Maybe it's a bog standard surgical pathway. Then there's little room for errors there. But a lot of the time we're dealing with people with complex needs. We're dealing with complex patients who have multiple morbidities and multiple different areas of care that they interact with. And when we transition between different areas, it's not just the episode that we're looking at. Like, we also need to look at the person that surrounds that episode. So somebody may be going into hospital for a hip replacement, but we need to understand all of the other aspects of that person's health and wishes as well, right? They might be comorbid with other conditions. So in those transitions of care, if we're looking just at the specific pathway, we miss the person. And that's where I think an EPR can often fall short, and where a shared care record, that type of platform, can really help, because the shared care record captures that whole patient picture. all of the information around the patient, irrespective of the episode that we're dealing with at the moment. And we need to bring that in because it makes a difference to how we manage that episode and how we manage the ongoing care of that person when they transition out of the setting that we're in. So I think how it impacts people is, as a clinician, if you are accepting somebody into your service, you need to then spend time emailing, phone calling, looking at other systems to make sure that you have the whole picture. When you're trying to transition them out of your service, you need to make sure that those support facilities and functions are available to that person so that you're not putting them at risk. And all of these things take time and they take effort and they stop you from doing your actual job.
Yeah, no, totally. And I guess the impact there, Ian, and by the way, I can see a couple of hands up. We won't be able to kind of bring you into the audio, but if you want to put a question in the chat, happy to look at that. But Ian, so I guess just on that point, what is that impact then? What would you say that the impact of that not being in place has on a patient and on a clinician?
Well, it's on the patient, it's having to tell your story so many times.
Yeah.
Which can be, one, frustrating, but in many cases it can be really traumatic, right? Because it depends on the story that you're telling. If you're talking about a difficult diagnosis that you've recently had that you're coming to terms with, having to tell that story over and over again can be really traumatic.
Yeah.
But at the most basic level, it's incredibly frustrating and time consuming and open to error, because as you tell a story over and over again, you start to leave out details, right? You cut to the chase more and you leave out things that you think aren't pertinent, but might well be. And there's a really simple example. A while ago, I wasn't paying attention very well in the kitchen when I was making a salad and I chopped the end of my finger off, right? Just a little bit. It wasn't too bad, but I tried sorting it out at home, but after a day, it was still bleeding badly, and I realised I needed to do something, right? So I did the whole 111 thing, spoke to a paramedic. So I logged into 111 via the NHS app. So they had theoretically had my health record attached to my chat. Then spoke to a paramedic who then told me I need to go to A&E because I have to get a tetanus shot and whatever, right? So he booked me into the local A&E, so get there within an hour, fine. So I got there, and then in the A&E, I had 8 different interactions over the course of about 10 hours with various different people in the A&E, and every single time I met one of them, I had to tell them my health history and what had happened before we move on to the next point of treatment. And the treatment was very simple. It was just a sterile gauze dressing and a tetanus shot, and that was it. And off I went. But it was 10 hours of telling my story over and over again. And I was sitting there calculating, and I thought, well, it's taking me about 5 minutes to tell the story every single time, right? That's quite a lot of time. But I'm a really simple patient. I don't have complex health needs, and it wasn't a complex problem. There were people in there who had dialysis issues. There were people in there who had language issues. And there were about, it's a standard A&E, probably 300 patients in a day. You calculate the time wastage there. It's absurd to have to tell this story over and over again. So that impact of the patient telling their story over and over again, you look at how it impacts the system. Once you aggregate all these patients together, it's unsustainable.
Yeah. No, totally. It is about having that consistent message, only saying it once, the patient, the record following the person, right, as opposed to everything being in silo. And I guess that's the key, right? And we've often spoken before, Ian, and I know you've alluded to it, that that EPR systems themselves are not enough. And with that said, what would you say is the biggest kind of design limitation that keeps them trapped inside the hospital walls? And what role can the shared care record have in that in that ecosystem?
So for me, the biggest design limitation of EPRs is the problem that they're designed to solve, which is the management of people through an acute setting. I mean, that's what an EPR is designed to solve, is the management of patients through acute settings. And some do it extremely well, some less well, right? Whatever, right? It's a really complex setting and it's very hard to get right. And all the focus is on how do we get patients through these settings and we get them on the right pathways and we prescribe the meds that we need and we record all of this and then it can eventually flow back to the GP record.
Yeah.
But we're looking at solving the problem of how we get people through acutes. And if we constantly focus on that problem, all we're going to do is have to make the bucket that we're trying to fill bigger and bigger and bigger, right? Because that bucket is people get sick and they come into acute settings and we have to treat them. And then there's holes in the bottom of the bucket where people are drained out the other end and they're discharged from that setting. And there aren't enough holes in the bottom and the bucket's not big enough. So the acutes are constantly under pressure. If we constantly focus on how do we manage this better, this bucket, we're missing the point that we need to turn the tap off. We need to intervene with people upstream before they get to the acutes. And EPRs aren't designed to do that. EPRs are designed to manage the acute. And then they kind of have started spreading out a bit to link better with primary care and to link better with mental health services and other things. But they're only linking to sort of help smooth that problem out in the acute setting. They're not linking out that way to manage people before they get to the acutes, even when we get to things like virtual wards, because that's still an acute function.
Yeah.
We should be looking, and what a shared care record can help do, especially as we build towards a single patient record, is help people take better ownership of their health, access the services that are available to them upstream, and manage their conditions better, or not deteriorate the conditions in the first place.
Yeah, and just a very, there's a slightly longer comment there. Sorry, I'll come back onto that in a second, Rob, and good to see you here on the call. But a comment actually from a clinical colleague, Ian, in London, that says that the problems that you're describing in A&E is not a single care record issue, as they would have been and should have been using a single EPR. It's perhaps poor work practice, and the problem of getting patients through A&E or an acute setting is not caused by a lack of a single care record. So I think the suggestion there is it's process, it's culture, it's people.
Sure.
What's your response to that? And thanks for that
I take that. I take that point, and I think that's correct. But I also think that if we did have that sort of more accessible single patient record that was linked to the NHS app, was linked to the triage conversation that I'd had with a paramedic, and provided a view when I got to A&E that was, this is Ian, this is what we know about Ian, this is the condition that he's come into A&E for, this are all the leading up circumstances, then everybody would have at least had that. And I take it is poor working practice, but I think part of the poor working practice is not having the tools to support them. Part of it is being overrun, just because that A&E was overrun, right? I shouldn't have been there for 10 hours, but I thought 10 hours was actually quite good, considering that how much I know the system is under strain at the moment. But I do think that we can support better working practices with better tools.
Yeah, absolutely. And I will come to Rob's comment. Just there's a lot coming through, guys. It's great. Keep them coming. If we can't get through all the comments and questions, we will try and respond offline. But there's a comment from Rob here that says, that he feels it's more that the NHS app needs to be the aggregator for patient-facing notes. However, the infrastructure to enable this isn't there yet. This is hopefully what the single patient record will help to achieve. In terms of behind the scene for healthcare professionals, the same infrastructure can enable interoperability, but a lot of this relies on the data platform being there. Where EPRs have developed, each EPR provider has their own data structure. Without some kind of broker/middleware, it's difficult to ensure no loss of translation, and slowly data standards are getting out there, but there needs to be brokerage. So there needs to be a brokerage service in between that to ensure a common language when feeding into the national systems. Just your 2 pence worth on it, and very much appreciated, Rob. So yeah, I saw you nodding there, Ian. I think that's a fair analysis, isn't it, in terms of the NHS app and the standards and all the different parts of the jigsaw that need to come together to make it really useful and usable and used, right?
Yeah, I wholeheartedly agree with that comment. I mean, this concept of the NHS app being the aggregator, I love it. It really should be where we're going, and it's what we're trying to do, right? And we're getting better engagement with the NHS app teams, and I know that it's front and center in the 10-year plan, and we'll see how that washes out eventually. But this concept of sort of black box data layers that are impenetrable and unmanageable and undecipherable is a real problem. This journey towards data standards cannot come quick enough, I think.
Yeah. We've got a few standards people on the call, a couple of names that I recognise, so I'm sure they'll all be agree with you on that one. So that's great. There's one more that I'll just mention, and you can just smile and nod, I think. But one of the comments says, in one word, what breaks when patients move between settings? And the answers are radiology and process. So I think that's an interesting one, isn't it? All routes lead back to those two. There's a question. So I suppose just coming back onto this kind of theme, really, of moving from EPRs or coexisting with EPRs and the single patient record, I should say. If there's a region that already has a national or kind of a regional, shared record, where does it kind of still stop? What's that cross-border flow, that write back, that citizen input? What does that mean? Because we're talking about coexistence. So I guess the question is, what is that coexistence, and how can we make it better?
Yeah, so I mean, most shared care records stop at an ICB/ICS border, right? Because that's where they were purchased. And then they will border another shared care record, which might be by the same provider or might not. There are some larger shared care records, like up in Yorkshire and Humber and Greater Manchester and things like that, which cover, and obviously in London, which cover multiple ICBs, but are joined together in one system. But ultimately, they have a border, and it stops there. And this is what the National Interoperability Programme is helping to, or hoping to mitigate, is that concept that people don't live within these borders and never stray outside them. Some people live on those borders, and they're really challenging because they might go to a GP in one place and a hospital in another place, right? Some people holiday regularly, different places of the UK, and that causes issues if they require health and care services when they're outside of their local region. So publishing and consuming data from the National Record Locator Service is really key. We're all doing that. All of us shared care record providers are doing that. We've got some of the way there. By early next year, we'll be, I think, most of the way there with that connectivity, and that will be really key. But then you mentioned also that the sort of contributing data, right? So really, shared care records stop at that whole contributing data thing, which is a real challenge. I think they were purchased as view-only platforms, and I think, looking back, I don't think they should have been. I think a shared care record should be more than a view-only platform, and we shouldn't have to have this fight about moving a shared care record from view-only to do. Because once we start bringing together care planning, especially complex areas of lifelong complex areas of care, so frailty, end of life, personalized care and support, those functions sit really well in a shared care record rather than an individual provider system, because they don't belong to a GP or a hospital or a social care setting, right? They follow a patient for a period of time, probably for the rest of their life, and they need updating regularly in any setting that a patient might be in, and they need access in any setting a patient might be in.
So this is great, because the way that you ended that comment, Ian, and the conversation in the chat and the next set of questions I wanted to ask you have all kind of come together there, because a comment again from Kevin, and I will come back to Mariam's question as well in a second, but the comment was, one thing you need in a shared care record is the ability for a patient or clinician to correct incorrect information. This is virtually impossible currently, but we need better ways to correct erroneous data. And while some might think that single care record means no one needs to repeat themselves, would you trust your hospital's EPR to inform clinicians? So, what I wanted to kind of ask you next was around that federated model and that real-time integration and how we make it work, and what shared care records are like today and how we envisage them in the future. But I think that question with Kevin's comment and answer, I think is kind of, it's half answered that for you. And I think you were nodding, so you probably agree with that, right?
Yeah, look, frankly, patients don't have enough agency to correct the information that's in their record. And this is really challenging, right? Because there's different types of information. And look, if I wanted to update my phone number, for instance, that shouldn't be a controversial thing. It should be relatively simple for me to do that, because it's a phone number. It's not massively important. It's not clinical data. If I wanted to update my end of life wishes and escalation of care, that's a different story, and that's probably not something I would do without a discussion with a clinician happening at the same time. But absolutely, people should have the right and the ability, citizens and clinicians, the right and the ability to correct information that's incorrect. And it starts to get really, really important when we're talking about people moving towards the end of their life, and who needs to be contacted about things, who needs to be brought into discussions, what happens when a person is taken out of their domestic setting and put into hospital for a reason, right? How does that impact the other system, right? Because we might have somebody who's elderly but is also a carer for their elderly spouse. If we put person A into hospital, what does that leave person B? So I'm straying off topic, but I do that.
No.
But it's about this ability to update information, and I think the NHS app has to be the vehicle for that, for citizens to do it. As long as you have a robust authentication mechanism, so we know who we're dealing with, we know that it's the right person who's logged into the app to do this, and they have access, they have the right to update this record, and we limit it to information that can be updated autonomously by that person, irrespective of a clinician being present or involved in the conversation, then it should be doable. Where that updates the information is the interesting thing, because who owns the source data? Is it in the GP record? Is it in the hospital record? Does it live in the NHS app? So that's where we get into the question of what the single patient record is. Because for me, it's a service that brings together information from different systems. It's not necessarily a repository of data itself. So we have to work out where do we actually update that phone number, if you like, or that my neighbor Ron comes around and looks after the dog when I'm in hospital, that piece of information.
Yeah, absolutely. And interestingly, and again, I'm name calling people here. The chat's going crazy, and there's something that we're saying that's obviously resonating with people, which is great. Nice to see Andy on the call, a real guru in this space. So, and he said the caution is needed here to ensure that the context of the data is fully understood by the receiving EPR, otherwise it can introduce clinical risk. This was the lesson from the UCP in London when integrating with acute and primary care systems. Not so much a technical issue, but more a health informatics one, which has got a couple of ticks there. So I think, and also just to give him a great shout out, because I know he's dialing in all the way from Texas. So it's great to see you on the call as well, Richard, who's been giving us a long list of things to kind of answer that question around how the shared care record needs to look, what it needs to look like in the future. So and some of the challenges around fragmented systems. Timing, failure, especially discharge patients, patient experience, care continuity, errors and readmissions, flow and coordination, bed shortages, cost inflation, trust and experience, lower satisfaction. I mean, the list goes on. So I think Andy's point, Richard's point, Rob's point before as well around, there's a lot more here, isn't there, than the technical capability. And I think that's the point that we started with before, isn't it, Ian, on those 5 principles and what that white paper is basically saying, which is work with what we have, don't ignore those non-technical aspects of what will make a single patient record vision a reality. And not to put pressure on anyone in the room, but I know that we've got John Farrington on the call with us, former NHSE kind of architect of some of these big national programs that you're talking about, like Record Locator. Nice to see you, John. Interested in your views as well. But what does it look like in the future, Ian? Because obviously there is so much kind of technology. There are so many complexities. There's so much nationally, regionally, but even organisationally, to cut through. And how does that coexistence? If this is an opportunity to coexist in a different way, what does that look like? How do we get there? How do we solve some of these kind of meaty issues?
I mean, it's not a small question, right? Like, if I knew the answer to that, I'd probably get the Nobel Prize. But
yeah.
So I mean, predictably, because of where I work, right? I worry that these assets that have been built all over England, bringing together really difficult data sets and making
Yeah.
sense of them and transforming them into sort of movable data. I worry that they will be forgotten, discarded, and some attempt be made to build a kind of fully centralized, aggregated view of all of the information starting from scratch, which I don't think is achievable. Um, even if the putative £10 billion budget for the single patient record is real.
Yeah.
I just don't think you'd ever get there. So I think what the future looks like is you have to start with the foundations that we have, which is challenging because they're not all the same. Not all shared care records are created equal, even from the same supplier. So not all Orion shared care records are the same. Right? We
Yeah.
have different types of data in the shared care records, depending on which GP provider it is, depending on which hospital provider it is, right? We have different levels of maturity because we've got some shared care records that have been around since 2013 and some that went in last year. So, not all shared care records are created equal. We have to look at that. We have to look at what's the base level that we can all start from. We have to look at what the gaps are between what a shared care record is as a viewing platform and what a single patient record should be as a viewing and contributing platform. And then I think the future looks like every single major shared care record provider getting around the table with the single patient record team and the Ming Tangs of this world and the Jim Mackeys of this world and coming to an agreement about what standards we are going to use and what data sets we are going to use to produce this layer that is, viewable wherever you are, up to date wherever you are, and can be contributed to in a sensible in a sensible manner. But it looks like the data already exist. Most of those connections already exist. We need to push those into a sort of a central function, aggregate them in a way that you're removing duplication, because we will have the same pieces of information recorded in multiple systems. And already shared care records take those allergies from 3 different systems, and we say we aggregate it into one view that is a peanut allergy. We have to turbocharge that function, I guess. That's what the future.
Yeah, no, absolutely. And even and a similar theme to what we were talking about before, Ian. Mariam was put in the chat that you were spot on, Ian. Where should patients change the data if the SPR is just a viewer rather than a repository? And that's the $1 million question. So, it does feel like there are perhaps some more questions than answers on this. Obviously, if people like Ming and Jim Mackey, etc., are listening or get a chance to look at this, obviously we'd be happy to have that conversation, right? We want to be engaging and kind of continuing to make sure that what we create, what we build, that impacts on all of us as individuals, as patients, citizens, etc. That it's the right model and it's the right solution. So we've kind of spoken about it broadly, Ian, but what would you say, and obviously to people around the table as well, what are the benefits of a single patient record? Who gets the benefits? What does it look like? Because obviously we're talking about the challenges, and we know that there are lots of them to overcome. But actually, what about the positive, the benefits? What will this enable that's not in place now from a positive perspective?
So I think there's an interesting comment there from Simon about the NHS app being if the NHS app were a data repository, it would remove the need for the GP record to have primacy. And I think that's the point, is at the moment the GP record is seen as that sort of prime level of patient data, right? And the GP is the arbiter of that information. What the single patient record should do is make the citizen the owner of their health record. Right. And that doesn't mean that they access every piece of information in there and that they have, ultimate gatekeeping capabilities of you can see this and you can't and stuff like that. Because we have to be sensible about health and care data for direct care. This concept of opting out of sharing those information to a point is challenging, because people have to have the right to care for you, and they have to have the information that they need to care for you, even if you can't communicate, if you've been in an accident. However, the ownership of the record should be with the citizen. The ability to take some agency over what they do with their health information should be with the citizen. I think the point of the single patient record, where it challenges the status quo, is, and this was, you know, a discussion you and I Hadley had with Deborah El Said in Bristol, North Somerset and South Gloucestershire ICB, about what's the point of a single patient record. The way health information has been organized is organizationally centric. It is organized around a hospital, around a GP, around a mental health trust, and it's pockets of information, and they are silos, and they are kind of blurred by things like shared care records and some sort of interoperability, but they are still organizationally centric bits of information. This belongs to the hospital, this belongs to the GP, this belongs to the mental health provider, this belongs to the social care provider, the local authority, whatever. The single patient record changes that and makes it a citizen-centered view of information. And I know, you know, it's a one of those kind of pitch terms that everybody likes. It was patient-centric information, but it removes it from being centered around an organization to being centered around the person, and that just follows the person. And it is really, really challenging. And I think somebody mentioned something about financial services as well. And I think back in the day when the spine was being created, somebody from financial services said, whatever you do, don't make this organizationally centric like we did in fintech, in financial services, because it caused us massive problems. And lo and behold, healthcare made it organizationally centric, and it has massive problems. Yeah. So the benefit of the single patient record is it means that wherever you as a person go, you have access to the information you need to show people, whether that's end of life wishes or whatever, right? Or information that you need to consume about your own health. But you also know that when you go into a provider of health and care, just because it's not the one that you were in before doesn't mean they can't access the information they need to care for you properly.
Yeah, absolutely. And so I guess there's benefits there at a system level, hopefully at a commissioning level, obviously at a patient level. And you know, it should also introduce efficiencies, really, shouldn't it, Ian? You know, fewer repeating yourself, eliminated, fewer test, instances, less picking up the phone and having to find out, where a particular bit of information is, right? So it's operation. There's operational benefit as well as kind of organizational, I suppose, as well as the patient.
Absolutely.
So no, that's really good. So I think, I wanted to kind of ask you about how we empower patients and professionals, how we collaborate across those individual and trust organizations. And, I think, and I'd be interested to hear from colleagues around the table as well around, do you support? And I think the answer is yes, because we've spoken about it briefly, but, would you support giving patients the ability to update parts of their record? And I think the answer is probably yes to that. But I guess the off question of that question is, but how and what does that look like and what does it mean? And it might be that also might be the second $1 million question from today. But, is the answer yes? And the NHS app has that kind of responsibility to ensure that key bits of information can be updated and that bidirectional interoperability exists with those host systems so that it's not kind of being missed and it's not in one place and not another, or is there something else?
So I think the answer to the question, should citizens have the ability to update their record, is yes, with caveats. But we've talked about that, right? You can update demographic information, right? Address, phone number, stuff like that should be relatively simple. You absolutely should be able to update personalized care and support plans, goals, actions, things like that. Because if we want, so the NHS 10-year plan says everybody should have a care plan. Everybody should have a care plan, right? Not sick people should have a care plan. Everybody should have a care plan. And in that, we should have things like goals and actions, right? So it might be that you have a goal that's set for you with your GP, that is, you need to lose a little bit of weight. And there's some actions that are associated with that. Or you need to lower your cholesterol. And there are some actions that are associated with that. As a citizen, I should be able to update what actions I've done. There are, other circumstances when I got an ADHD diagnosis when I was 42. The first thing they do when you're an adult and you get an ADHD diagnosis is they put you on meds and you go through a titration phase. I would have loved to have had a contribution, the simple contribution by the NHS app that could say, this is how I'm feeling today on my meds, because I really did not take to the meds, the ADHD meds. They really made me feel stressed out and on edge, and headaches, and my vision went blurry. I would have just liked to have been able, because it was very difficult to get hold of the psychiatrist and have a face to face, and we really didn't need it. I just needed to be able to say, took my meds today, I felt like this. Like,
Yeah.
or the anxiety that I'm feeling from my meds is growing every day as I take the meds. And the psychiatrist could look at it and go, reach out and say, we're going to change the regime because this doesn't seem like it's working. That kind of contributed data and updating data is really, really useful. The vehicle has to be the NHS app. I don't see how it can be anything else.
Yeah, no, absolutely. And I guess we're, not for now, Ian, obviously, but there are clearly then certain use cases where that needs to be applied, and where it can have meaningful kind of impact, right? Gosh, there are some real names from the past on this call. It's great to see everybody, and it's nice to see you, David, and thank you for the comment around kind of consistent info isn't necessarily the benefit, it's the feature. Patient benefit lies in how that information improves their care, e.g. fewer patient safety incidences. And when we don't identify and quantify those benefits, we miss the opportunities to get more value for the right people. So I know David has spent 30 plus years, in benefit realization activities. So I'd expect nothing less from you, David. And I totally agree that it is about tracking it, isn't it? It is about following that journey, that feature, that enabled kind of piece of functionality, isn't it, to really show the impact that it can make, which I think we all agree with. And Simon's got a great comment as well. If he had a wish list, he would want the ShCare record to hold a real-time list of medications that a patient was prescribed / using that can be changed in real time by care providers, and that would ensure that changes between transitions in care would be readily evident. I guess you agree with that too, right, Ian?
Yeah, 100%. And I'd go even slightly further, that a patient should be able to contribute to that by saying which over-the-counter meds they've purchased as well, or taking as well. I know that's challenging because some will and some won't, and some will have a better understanding of this. But if you are engaged in your own health information, yes, you can get a list of meds that have been prescribed to you, and yes, that can be augmented with a list of meds that have actually been dispensed to you, but we don't know if you've taken them or not. But equally, there's no record of if you've gone into Boots and bought some cocodamol over the counter, which is quite important, because if I notice that if somebody's giving me an updated, curated list of medications and they say they're taking cocodamol every day and have been for 2 weeks, I'd want to know why they've been in pain for so long.
Yeah, no, absolutely. And again, sorry for name calling, but Karina, I can see you're on the call too. Prominent CCIO within the EPR space. It'd be interesting to get your view from a clinical perspective. And just to kind of go back to kind of the strategic part for a second, then, Ian, just whilst we're having a bit of a think about that, like in terms of that 10-year plan, so we're already a little bit into the year one of the 10-year plan, how does all of this connect, do you think, with that 10-year plan? Do you think it's a good mechanism to achieve that change? Do you think it's realistic? Where does it fit into the broader picture, do you think? And I know that, as we said before, there's some white papers that have been produced by HIC and Orion that might help to partially answer that question, but just what's your reflection on where it sits really within the next 10 years of digital transformation?
Yeah, I mean, it's not going to surprise anybody to say that I think I'm working in a space that's trying to support the 10-year plan, right? And I think that if we follow these things, that we will help support some of those activities. There's obviously the three main pillars of moving from analog to digital. Yes, this ticks that box because this is what we're talking about, taking away some of those analog processes and moving them into more logical digital systems that are accessible kind of anywhere. The move from hospital to neighborhoods is frankly exactly what we're talking about by moving some of this integrated care planning into ShCare records, moving some of that coordination away from hospital acutes or primary care systems, and saying that it's a whole system approach, and that everybody has the access to the information that they need and the plan that they need to help people. And then obviously that kind of move from treatment to prevention.
Yeah, no, absolutely.
This is what we've been talking about agency over your own health information, and then digital access to services that are available to you before you get to a point at which you've deteriorated quite badly. The primary care access is a problem. If I phone my GP at 8 o'clock in the morning, I can guarantee you I'll be number 50 in the queue, and I may or may not get through that day. I almost certainly will not get an appointment that day. The only time I phone the GP is if it's for my son, because I'm more worried about his health than mine. And he would probably get an appointment because he's very young. But most of the time I don't actually need the GP. I need access to a service. But I need to speak to the GP to get the access to the service. I log into the app and I say, this is what's going on. And it could say, well, okay, this is the right service for you. You can self-refer. You can book an appointment here. You know, this is what we're talking about in terms of this sort of preventative model.
No, 100%. And I'm going to come on to a question that, you would expect me to ask Ian before I then just read out Karina's comment. And thank you for putting that in, Karina. It's very helpful. But just a question and a point that we've not spoken about, but from a governance perspective, that dreaded word, or that dreaded two words that we all know about. What do you think is needed to enable kind of patient contributed data to make it, and equally to have that updating mechanism and all the extra kind of really beneficial elements that you're describing, Ian, to make it safe and valuable without overwhelming the front line? What governance wrap needs to go around all of this? What does that look like?
We're now straying into an area that I'm less comfortable in, and IG is a problem. So look, I think there needs to be legislative changes, and I think there are in the workings legislative changes to support the single patient record. So it's fundamentally data sharing agreements probably need to change, especially around shared care records, because they were originally signed as a view only platform, and now we're starting to do stuff in shared care records, and that's a bit different. And especially if we use those as the foundation to build a single patient record, I think it's going to stray quite a long way outside of what the original scope of work was. And where the original sort of information governance sat, and I think it would be uncomfortable for people to move too far in that direction without a change to those agreements. I think so. There's two areas, right? There's the making sure that the right person has access to do what they need to do with the information, and that's a robust authentication mechanism. But I think NHS login is a pretty robust mechanism, and if we're using the app as a vehicle for citizens to update their data, we already know that we're trusting that mechanism to allow them to view their health record, and we wouldn't trust that mechanism if it wasn't robust. Then we just have to decide, what do you allow people to actually update, and that's an IG discussion, but it's not insurmountable.
No, but
I think in terms of the wider governance, it has to be covered by legislation.
Yeah, totally agree. I think that's spot on, isn't it? I think, and it's easy to say, isn't it? But I think when big transformation through these digital systems, and we're talking about such different ways of working and empowering clinicians and individuals around this data, that legislation has to keep up with that ambition, doesn't it? It can't be done in silo. And interesting, just to bring back Karina's comments. So she says she agrees with others' concerns around fragmented data not mapping easily and enabling patients to change values is the right thing, and the NHS app is the right place, but need a strategy for digitally excluded. So the data mapping diagram you showed looks like the right thing to do. As a clinical person, we really do need one source of the truth. So I think we're all in agreement with that vision and that kind of architecture almost. But that governance question is an important one to say, but actually it might be technically possible, but if it's not legally possible, then that's a big hurdle, isn't it, that needs to be overcome. And I just kind of worry slightly that maybe the nuances of what we're talking about, and what the SPR team are talking about, what the 10-year plan wants to achieve, has maybe that legislative kind of program is maybe not quite caught up with the ambition. So I hope that the two do come together, and maybe that's something that we can, as a community, actively think of,
and it's definitely, it's clearly in the works. And I heard Ming Tang talking about this a few months back about that requirement for legislation change, and a need to focus on that quickly. The problem you have there is legislation isn't easy to change, and it takes a long time. And even when you have a government with a large majority, it's still not going to be straightforward, because not everybody's going to agree on. It's a really touchy subject that I think is open to wide disagreement about the best ways forward.
No, exactly. Interesting question, Simon. We've got to meet offline. I'm really loving these questions. Very valuable and very helpful. How do we feel about the agenda being hijacked by clinical groups, e.g., GP leaders calling for industrial action, ballot over GP Connect concerns, for example? It's an interesting thought, isn't it? Power to the people and all that good stuff, right? What do you think, Ian? Do you agree?
Yep.
It's happening, isn't it? I can see the picture in the chat. Yeah, there is a call for that. So that's an interesting one. We've covered a lot there, Ian. It's really flown by in 55 minutes. We've got a couple of minutes, I think, now just for questions. I think my colleagues at HIC are going to maybe put up some contact details for you and myself, and not sure if we've got a reminder about the EPR summit in Wales next week. But if we don't, and you didn't hear it at the beginning of the call, we are there next week. It'd be great to see you there if you can join us. But there are our email addresses. We're obviously on LinkedIn as well. We look a bit more polished there, don't we, Ian? But still look good today. It's all good. Thank you for sharing that, Ree. So I guess just any kind of questions then. Sorry. So the EPR summit in England and Wales. So the Welsh one is coming up next week, as I said, and then EPR Wales in March. So if you'd like to come and attend that, please do so. And if you're interested in sponsoring, obviously you can get in touch on that as well. So just any other kind of final thoughts? There's a long comment in the chat here. I might not have time to get to it. But it's from John. Okay, John, I'll try and get through it. So John's suggesting that we need to reframe the thinking. There's only one constant in all of this, and that's the person receiving the care. Totally agree with that, John. We're constrained by thinking more about the institutions and the individual. The language of our conversation today reflects that. What might be good if we could engineer our thinking around the individual receiving the care, regardless of where or who provided their care. Easy to say, much harder to deliver. You support Andy's earlier point about the importance of semantic meaning. We're in a better position today than we were in 2018. There's political pressure to perhaps do something in line with the electoral cycle. We need to make sure that it's the right thing. And for me, a key lesson learned is that it's a less technical issue, but rather about people, relationships, and trust, which I agree with totally. Any final thoughts, comments, Ian, to kind of conclude today's webinar?
No, John makes an excellent point, as always, that you have to worry about fitting something into the electoral cycle. And that's always been the challenge with health and care, because it's so politically charged, and because we have a politically appointed head of the health service, right, that's just the way it works, that it has to fit into a 5-year cycle. And the danger of doing something to be seen doing something and getting it wrong. This is not a small thing that you can unpick easily. If we do it wrong because we're trying to fit it into an electoral cycle, we're really just, there'd be dragons in their waters, right? So I would suggest to the government, if you want a quick fix, there are other quick fixes to do, but focus on doing this right and do something to get the electorate on your side. Something else to get the electorate on your side to get you voted in for another 5-year term.
Absolutely. Well, we're not going to get political. Thank you so much, Ian. There will be a feedback form link going into the chat shortly. Would really appreciate everyone's time just for a few minutes to complete that. Helps us make these webinars, even better. But that's all we've got time for today. I'd like to thank Ian from Orion Health for today's session. Thanks for our partnership, and you know, it's really great working with you and team. And obviously, there'll be more of these webinars coming up, so look out for them. I think the white papers that have recently come out from the EPR network have also been shared in the chat. We look forward to continuing the conversation with you. If we've not been able to get to your comment today, we will reach out offline. Hopefully we'll see you in Wales next week, and if not, then in Birmingham in March. So with about 20 seconds to go, we'll conclude the call there. Thanks so much to everybody, and yeah, have a good rest of the day. Thank you so much.
Thanks, Hadley. Thanks to Ree and Colleen and Jasmine and everyone for making it happen.
Thank you. Take care.